Good morning, everybody. Lovely to be here. Usually, when I speak, I focus almost exclusively on growth because growth is obviously a big issue for Costello and the rhasopathies. But actually, this time, I'm going to widen out what I talk about and just talk a little bit more around hormones in general and some of the other hormone problems that have been described in Costello. So we'll start with growth, and I'll just take you through a little bit of normal growth, and then managing the short stature, particularly in relation to Costello. But what I say applies to CFC and Newman's. And then I'll talk a little bit about puberty and normal puberty, and then some of the abnormalities that can occur in puberty. And then I'm going to mention blood sugar problems, because they come under us as hormone issues. And just at the end, I'm going to mention something about calcium. So this is an average growth trajectory of a child. So over on the left-hand side here is when you're born. So you're not born at 0 centimetres, you're born at about 50 centimetres. And a child in infancy, in the first year or so, grows very quickly, but they're decelerating. And then through childhood, on average, children grow about sort of 5 to 8 centimetres a year. And then when you get to puberty, you have that pubertal growth spurt, so that's this phase here. And that's the hormones that come about from puberty, so the estrogen, the testosterone. They are what fuse the bones and stop you growing. And children should, by and large, fall into a region on the growth chart as determined by their parents' height. So that's what happens normally. And one of the things that we check for a child when their growth isn't so brilliant is to measure a bone age, and that's just done on a wrist X-ray. So you look at the development of the bones, development of the growing ends of the bones, and that can be turned into an age. And what often happens if a child is short is they tend to have younger bones. So their own age, say, will be 10 years, and on the X-ray, the score for their age might be 7 years or 8 years. And that's a good thing because it means you've got a bit more growth potential. So that's one of the checks that we do. So these are the growth charts that we primarily use, and I suspect many of you might have seen your own child or even keep your own growth chart. On the top here is height, and we're running here from birth up to 20 years, and the bottom sets of lines are weight. And then there are the timings of puberty at the bottom here, and I'll come back to that. But what's represented on here, these are called centile lines. So somebody who's growing on this one in the middle is on the average line, so that's the 50th centile. And if you're tall, you're up here. If you're short, you're down here. And the sort of pink zones are where you're starting to get rather short or rather tall. So we plot a child's height onto this graph, and if the height is falling below this bottom centile, the 0.4th centile, then that's considered to be quite significant short stature. What 0.4th means is that 99.6% of children are taller and 0.4% of children are shorter than that individual. So the further down below the line here, the more likely there is to be a major cause for the growth problem. Now, we always have to think about a child's height in relation to their parents. And we have to do a little bit of trickery, well, not really trickery, we have to do our sums to correct the parent height. So this is a girl's chart. We have to takes some height off the father's height to get them into the right zone on the girl's chart, and then that gives you a target range. So actually, if you had a short child who had short parents, that would kind of fit. Although, of course, if your parents are very short, then for me, I'd worry about there being a problem in the parent. But you can calculate these, and usually the zone will be somewhere up here in the normal range. And if your child is a long way out from the parental target, then clearly there's a problem. And you can look at one measurement and work out quite a lot from one measurement, but what's really useful is serial measurements. And the serial measurements will allow you to generate a growth velocity. So in this particular case, this child's actually grown quite well because they've gone from the 0.4 to the second centile. And that's how you make up the number of centimetres grown in a given period of time. And if you're growing less than about 5 centimetres a year in the pre-puberty years, which is these years, then you're going to start falling away from the lines. So many of you, I think, probably will have the red book, and the red book has these graphs at the back, so you can do this yourself. There are a very large number of causes of poor growth. And here's a list of them. I don't need to go through them in huge detail. Of course, around the world, probably lack of food is the principal reason that children grow poorly. But we recognise a large number of conditions which can be associated with poor growth. Perhaps the classic one that we deal with in our growth clinics is Turner's syndrome, which is a condition in girls who are missing an X chromosome. But I've listed here the UK Costello CFC, the rasopathy. So they're a recognised condition now with an explanation. Of course, when we started, we didn't know what the genetic causes of Costello were, but now there are. And then there are still a number of recognised conditions that don't have a gene explanation. And then at the bottom here, we have hormone deficiencies. And in the sort of bigger picture of all of these causes of poor growth, hormone deficiencies are relatively rare. But I'm going to come on to talking about the combination of having a rasopathy and a hormone deficiency. So, this is my single quiz. These are two brothers. There's a growth chart over on the right-hand side there, and you can see from this growth chart that this child was very, very short and was falling away, so that growth velocity was very poor, diagnosed with growth hormone deficiency and put on growth hormone. So, of these two brothers, who is the older brother? Is it this guy on the left, or is it this guy on the right? Which one's older?
So you would probably presume the one on the left because he's taller, but it's probably the one on the right.
Very good answer, actually. They're twins. They're twins, and this one has got growth hormone deficiency. And we picked him up in mid-childhood, a bit like that graph there. So that this is not somebody with CFC or Noonan's or Costello. This is a child just with isolated growth hormone deficiency. We treated him, and he ended up taller than his twin brother. And that's fine, yeah. So what we're dealing with a growth pathway. So the rasopathies are all of those little signaling molecules which we saw on that super cartoon. They're all here. These are little signaling molecules, and they are activated through growth factor receptors, including growth hormone. Okay. So, when you have a child who's got significant growth problem, it's very important to look to see whether there is a deficiency that could be put right. And there are ways of going about doing that. Of course, the one that we're looking at for growth is particularly growth hormone. And we can do that in a number of ways. The single test IGF-1, insulin-like growth factor 1, and IGF-BP3, insulin-like growth factor binding protein, they are related to growth hormone. So when you have growth hormone in the body and growth hormone talks to the cells, they generate IGF-1. So you can measure that in the blood, and if those levels are low, that would suggest growth hormone may be low. But if you really want to have a look at growth hormone, you have to do a full stimulation test. So that's, your child would have to come into hospital fasted, have a cannula, have a series of blood tests. And that's a combination of looking at growth hormone and IGF-1 will give you an idea about whether there is growth hormone deficiency present. And if you're looking at the growth hormone, it's always worth looking at the other hormones, so your thyroid hormone, your cortisol from the adrenal glands, and if relevant, puberty and sex steroid hormones. So let's just have a look at some of these are rather old slides, but I think this one probably came from you, Colin. I remember you collecting in the early years some growth charts. And this is a boy, hence the blue, and this is the height and the weight. So you can see a number of things that I've already talked about. First of all, this child is miles below the normal lines, so very, very short. And also the velocity is very, very poor because the child is getting further and further away from the normal growth lines. And that is also associated with a rather poor weight gain. And then these are some other growth charts. These are in 3 girls, and we can follow this one, so height here. This child kind of tracked a little bit under the centiles, and then eventually achieved a final height of about 4'10". This child didn't do quite so well, and ended up with a final height of about 4'6". And this child here in the middle was really very, very short and had this poor growth rate and was started on growth hormone, and look how brilliantly they did, with a height starting to return to the normal lines. And that's also reflected in the weights here. So this child here achieved a very modest weight. This child achieved a weight just above into the normal lines, and then growth hormone also helped with the weight of that child in the middle. Okay. And you may be familiar with this publication. The data was assembled from quite a large number of Costello individuals. These are the growth charts for the first 3 years of life. Compared, they're actually combined males and females, but this has been compared to the normal curves for males, the normal curves for females. And on my previous charts, the normal bottom line is this red dotted one, the average that one, and the top one is the black one. And if you do the same centile lines for Costello, the lowest Costello one is here, the average here, and the tallest Costello children sit on the lowest normal line. So there's a little bit of an overlap and a range. And the same holds for the 0 to 10. So these are the shortest Costello children, the average, and then the tallest Costello children will just hit the lower end of the normal range. And this is a more recent publication, again showing a response to growth hormone. And you've got a child who is both short and growing slowly, in whom growth hormone deficiency was diagnosed, started on growth hormone treatment. You can see what a fantastic response that child has had, because without growth hormone, that sort of thing would have happened. Okay. So, just some general comments about growth hormone treatment in rasopathies. The condition in which there is the most experience is Noonan syndrome. And so it's relatively extensive experience. We know that it will increase growth rate. It does have some impact on increasing final height, not maybe a huge amount, but it certainly increases growth in childhood, and we're pretty comfortable that it's safe. But I think one of the things to think about with growth hormone is that growth hormone is a hormone that doesn't just act to make you grow, it acts on multiple tissues. And so it is good at keeping muscles strong and keeping the fat at bay. Because it keeps the muscles strong, it also helps to keep the bones strong. And it's a difficult concept to prove, but for some children it just makes them feel better and be more energetic.
I remember in the early 2000s there was some suggestion that growth hormone would help with Down syndrome and cognition.
I remember in the early 2000s the suggestion that growth hormone would help children with Down syndrome with cognition, and there was a suggestion possibly for the rhasopathies.
Yeah, I mean, those sort of studies are incredibly difficult to be able to absolutely prove. I think one of the things about, because in children born small for gestational age who stay small, a similar thing has been raised. Because if you make somebody taller and you make somebody more energetic and vital, you give them the opportunity to interact much better, and that often leads to a spurt in development. So I'm sure it's a real phenomenon, it's just exactly what the explanation is. Now, I think one always has to look on the other side. Are there any downs? Well, the use of growth hormone in Costello CFC is relatively anecdotal, although I've shown you some published literature, so it is out there. I think it is important to recognise that growth hormone deficiency has been described, so it's really important that that is looked for. And without question, there are clear benefits in individuals. But you do have to think about risks versus benefit. And we know that in Costello, tumours occur and may recur. There's a very big literature on the impact of growth hormone on tumour occurrence and tumour recurrence. And it's very reassuring to tell you that there is no evidence in large numbers of children who have been treated with growth hormone who have had tumours that it does not cause either occurrence or recurrence, which is very reassuring. And I think when you're treating in the situation of growth hormone deficiency, the other reassuring thing is that you're just kind of restoring normality rather than pushing levels higher than they should be. Just going back to the tumour occurrence recurrence, the work that's been done there is principally in children who have had brain tumours treated and then they've had radiation. But when I say there is substantial evidence, I really mean there's substantial evidence. The papers reflect thousands of children who have been treated. We recognise cardiac problems, and there's been a lot of effort looking at cardiac problems, particularly in Newman's syndrome, and really growth hormone has not to any extent in groups of children exacerbated the cardiac problems. Growth hormone works in an opposite way to insulin, so there are always worries about could growth hormone induce diabetes. Again, that has not shown to be a substantial problem. And I think you have to bear in mind when your child has quite a number of problems and maybe has to attend a lot of hospital appointments, have a lot of blood tests, that having growth hormone only, I'm afraid, comes on the end of a needle, and it's a daily injection. So it is a burden to child and family. I have to say, in our growth clinic, so we're a regional growth clinic here in Manchester for all of the North West, we have at any one time about 350 children on growth hormone for all different indications, and almost none of them have major long-standing problems with taking injections, because the injection devices are really very well designed, they're little needles. So I don't think it's a huge burden, but it is something to bear in mind for a very xenophobic child, for instance. So, what should your strategy be for managing growth? Well, I think it is worth having some paediatric endocrine input. So if your child hasn't seen a paediatric endocrine person, it might be worth asking at least to go once. Keep accurate serial measurements if you can. Not always easy. If there's a problem with the spine, for instance, that's going to affect growth. And if your child is significantly short, then I think it is worth having a look at those growth hormone and IGF levels. And then if you get to the stage where growth hormone is being contemplated, I think it's worth calling it a trial of treatment. And you need to work with your doctor and say, well, let's decide what sort of a response we want to see to decide whether it's worth continuing. So, if the growth rate picks up by so many centimetres per year. And I think it is worth doing the safety checks, so making sure that maybe echoes are done regularly, that scans, abdomen and pelvis are done regularly, and monitor the IGF-1. So when you give growth hormone, that IGF-1 level will go up because it's that makes the bones grow. And therefore, if the IGF-1 level is going too high, for instance, you could drop the growth hormone dose. Or if the IGF-1 level is staying very low, you've got some room to increase the growth hormone dose. So that's something that we would do in the clinical setting when we would see you for follow-up. Okay. So those are my comments on growth. I'm going to move on now to just say a few words about puberty. This, like the growth chart, is a normal distribution with small numbers of children who are short, small numbers who are tall, and lots in the middle. Then puberty, the age at which children go into puberty, there's an average age. So in boys, the onset is around 12 years of age, and in girls, it's a year earlier, to 11 years of age. But then there'll be some who go into puberty quite early, and there'll be some who go into puberty quite late. And, well, I'll come back to the extremes. Okay. So there is a well-recognised sequences of events that occur once your child hits puberty. So in the bottom here, for a girl, the onset of puberty will be when the breasts start developing, so you just see little breast bloods to start with. Then you get your growth spurt, and then it's not for a couple of years till the periods start. So the periods aren't the start of puberty, it's when the breast bloods start. And then once you get to when the first period starts, that doesn't mean that growth is ending, but it means you're moving into the last phase of growth. And on average, a girl will grow probably about 3 inches or so after the first period. So that's the sequence of events. In boys, their first sign of puberty is when the testicles start to get a little bit bigger. And I have this very high-tech device in clinic called an orchidometer, and this is to measure the size of the testicles. And blue means you're still prepubertal, and when you hit 4, that's the first sign of puberty. So that's here on here at around age 12, and then boys develop through puberty. They actually get their growth spurt much later in puberty than girls do. So you'll all probably recognise from friends and family how different boys and girls can be, particularly at that transition to high school, because the girls are always more developed than the boys are, which I always think is a bit mean. How does it all work? Well, the hypothalamus, which is right here in the centre of the brain, is the sort of controller. That works with the pituitary gland, so that's where growth hormone comes from. And the puberty hormones that come from the pituitary are called follicle-stimulating hormone and luteinizing hormone. And in the case of girls, they work on the ovary to allow the production of a number of hormones. Estrogen will be the main one you recognise, then that feeds back onto the hypothalamus and the pituitary. And as you develop through puberty and you get to your periods, then these hormones all start cycling. And a similar setup for the boys. The boys have two different sets of cells. They have the Leydig cells in the testes, which respond to LH, and that's what makes testosterone. And then they have the Sertoli cells, which make the sperm. And they have a similar feedback loop. So those are the details of hormones. Lovely. And if we just go back to our normal distribution, just click again and click again. Precocious puberty in a girl is defined as signs of puberty before the age of 8, and in a boy before the age of 9. So if things are happening before that time, then again, it's worth getting a paediatric endocrinologist involved. Now, sometimes you'll see, say, a little bit of pubic hair, but nothing else. So there are some innocent that's an innocent variant of puberty. It's for a girl, it's if breast buds start appearing and keep developing. Boys, it's the testicles if they start growing. And of course you can have the other side of the coin, which is a very late puberty. And in boys, that would be if you haven't gone into puberty by the age of 14, or in girls by the age of 13. And again, that's something that a paediatric endocrinologist could look at your child and advise you about. Oh. And if you want to know a little bit more about the precocious puberty side of things, I found a YouTube video which is one of the little sketchy things which I think are really powerful ways of communicating, so it's relatively easy to find on YouTube. So breast buds and testicles enlarging, those are the signs. If puberty is very delayed, or there's a hormone problem which means that puberty will never occur, then hormone treatment is required. And for a girl, that is predominantly with estrogen. As the girl gets further into puberty, you need to add the progesterone as well. And those medications are available as tablets or as patches. For boys, delayed puberty or absent puberty will require testosterone. Testosterone can come as an injection, it can come as a tablet, although testosterone tablets are not brilliant, or it can come as various sprays and gels. You have to be careful when you spray them. Precocious puberty, and I think precocious puberty is something that worries mums and dads a lot. And if your doctor feels that, and you feel that the puberty is sufficiently early to merit some treatment, then you have to block those LH and FSH release from the pituitary. And you do that with, I think the best way of describing it is a hormone blocker. It's actually a modification of the hypothalamic hormone, and that comes as an injection. They're very effective, but it does come as an injection. So again, it's not a minor undertaking, it's something the decision making is important. Okay, so that's my bit on puberty. So I'm just going to move on to blood sugars. And I'm going to talk about low blood sugars, because this is something that has been described in Costello. Now, Costello's rare, and these problems in Costello don't occur for every child, but they have been described in some. And low blood sugar, so glycemia is the sugar bit, and hypo is the low bit. So hypoglycemia. And one of the difficulties, I think, for children is that the symptoms of low blood sugar are multiple and can be quite non-specific. So there are all of these things. You can get shaky, sweaty, anxious, dizzy, hungry, fast heartbeat, impaired vision, weakness, headache, irritable. And of course, if that happens in a baby, that's kind of quite difficult to detect. So low threshold for looking for low blood sugars in babies. Okay. What controls blood sugar? Well, it's controlled in part by what you eat and drink, and the sugar content of what you eat and drink. But the key organ in the body is the pancreas. So the pancreas sits behind the stomach. So it's right at the top here. So it's behind your stomach. And it actually produces a whole load of hormones and compounds. One set of the things that it produces are enzymes which help to break the food down. So it's related to, it has a little tube that opens out into the gut. But the other thing that the pancreas does is release insulin into the bloodstream. So inside the pancreas are these little pancreatic islets, which are made up of a bunch of cells. One type of cell responds to glucose in the blood, more of these little molecules in the cell in the pathway, and they lead to the release of insulin. And what happens in some cases of Costello is that you generate a low blood sugar because there's too much insulin. So there's a kind of mismatch of this system, and the cell decides it's going to produce more insulin than is needed for the level of glucose in the blood, and therefore the glucose level drops. And that is called, rather long words, too much insulinemia, insulin in the blood, causing low blood sugar. Hyperinsulinemic hypoglycemia. You might hear that phrase or hear HH as the abbreviation. And there are a couple of publications around HH in Costello syndrome. And I'll come back to the management of that. But another item I just wanted to mention, because I think it has been something that's been raised by families, is this condition called dumping. It's a rather ghastly term. And it basically means food going rather quickly straight through the stomach into the bowel. And you see it very commonly in individuals who have had their stomach removed, maybe for a cancer, or they've had a stomach reduction to try and help with weight control. That's where you'll see dumping most frequently. But we recognise this condition in a number of childhood conditions, and there have been thoughts that this may be an issue with Costello syndrome. And so basically what is happening is the food is getting into the intestine. It is stimulating a large burst of insulin from the pancreas, too much insulin from the pancreas, and the blood sugar level drops. And so that's what dumping is, and that requires, well, if we move on to the next slide, requires modifying how you eat and diet. So I think general terms for low blood sugar, I think be aware that it is a possibility. It's particularly important to check it out in babies, because as I said, it can be difficult to know whether they are low sugar or not. And of course your doctors may not be so familiar with the possibility of hypoglycemia in the condition, so just raise it with them. Say, please just look at the blood sugar. And blood sugars can be easily measured, they can be done on finger pricks. And if there are worries about, say, in an older child, what the blood sugar, how that behaves over a 24-hour period, there are now some really good devices where you can have continuous blood sugar monitoring. So you have a little needle on the leg or the tummy, and you can record blood sugar all of the time, through the day, through the night, and that can be extremely helpful to check out whether there are dips in sugar that people don't know about. Now, if there is a worry about low blood sugar, one of the key things for us from a medical point of view is what we call the acute blood sample, which is a blood sample being taken when the child has a low blood sugar, because you can then measure all of the hormones to see which one is causing the problem. And if you have an acute sample where the blood sugar is low but the insulin is too high, you can immediately make a diagnosis of HH, hyperinsulinemic hypoglycemia. That can be sometimes a difficult sample to take, because your child's got low blood sugar, they're probably not brilliantly well, but the doctors have to rush in and get that sample and then give some treatment for the low blood sugar. Okay. Now, the hypoglycemia may be relatively easy to treat with frequent feeding or adding a bit of extra sugar into the feeds. That may settle down many of the cases of hypoglycemia. But very occasionally, including in the dumping syndrome, you might need to use some medication. That medication is called diazoxide, usually very effective. And for reasons that I think we don't probably all quite understand, that, for instance, the hyperinsulinemia tends to be a problem for babies in early childhood, and you tend to grow out of it as time goes by. So if it is quite serious and your child's needed to go onto diazoxide, the chances are it won't be forever. They'll come off it. Okay, well, my last topic is around calcium. And I think we all know calcium's good for your bones, vitamin D is good for your bones, so you need to have a nice balanced diet that's got calcium in it, that's got vitamin D in it, and you need to go out in the sunlight, which is why in Manchester most of the children are vitamin D deficient. But there is another hormone called parathyroid hormone, which has a very important role in just making sure that the calcium levels in the blood are right. And it does that through its impact on the kidney to make active vitamin D, which allows you to absorb it from the intestine, and it also leads to, allow calcium to be drawn out of the skeleton. And that gland is ensuring that the serum calcium level in the blood is as it should be. So this organ round here is your thyroid gland, which is in your neck. It's either side of your Adam's apple with the bridge in between. So that's where your thyroid is. And the little parathyroids sit on the back of the thyroid gland. So they're only little tiny glands on the back of the thyroid gland. And a little bit like low blood sugar, the problem here in Costello that's been described in a few Costello cases is high calcium levels. And the symptoms of that can be multiple and rather vague. So headache, not feeling very well, irritable, confusion, muscle weakness, thirst, constipation, anorexia. So there could be lots and lots of causes. And what's been described in Costello is where one of these little glands grows a little bit too big, it's called an adenoma, therefore generates too much parathyroid hormone, and that raises the serum calcium. So it's a rare problem in a rare condition, but again, it's something just to be aware of. Calcium is often checked in routine blood samples, and therefore it likely will just get picked up incidentally. But again, always raise it as a possibility, because your doctor might not know that high calcium is being described. And if it is raised, then it is worth having the opinion of a calcium expert. Now those, again, it's your endocrinologist, but there's sort of a branch of endocrinology who are particular experts on bone and calcium, so you can find one of those to help you out. Okay.
I had a question. So my son had hypertrophic cardiomyopathy, and the medication that helped was a calcium channel blocker. Would that also then
it doesn't, those calcium channel blockers don't have a major impact on the actual level of calcium in the blood overall. Okay, so just to summarise, I think the problem that you're most likely to face is the slow growth and the short stature. And we've talked about looking at growth hormone and thinking about whether growth hormone is the right treatment. We've talked a little bit about low blood sugars, particularly as a baby, but in childhood. Low blood sugar can actually also be related to growth hormone deficiency, not just to high insulin. Puberty problems, either delayed or precocious, or when your child, for instance, when your young lady has gone through menarche, that might move on to period problems. Now, the normal population can get period problems, but if you have period problems on top of another condition, it can be quite difficult to manage. So those are issues, and you may need an endocrinologist, or even if your child's getting a little bit older, a gynecologist to help out. We've just talked about high calcium. There are a couple of other reports about hormone problems. I'm not going to go into detail because they're just single reports, but I think the message is that there are hormone problems with Costello, and always go and seek the right advice. Okay, and I'll finish off and just recognise my colleagues in the endocrine team at the Royal Master Children's. Thank you.
Question?
Thank you very much indeed, Peter. He has got another meeting to dash off to, but if anybody's got any questions, I think.
Thank you. I got 2 short questions. If your child is on growth hormone, how often do you check the levels? Do you do that every year, every half a year?
So the IGF-1 level, which is the one that can be done on a single blood sample, we would check that probably a couple of times a year. If we found it was too low or too high, we check it more frequently.
Okay, so when you're on a good level, when you check that, then you will do that every...
So when you're on a good, I would still check it a couple of times a year.
Okay. Yeah. Thank you. And another question is, you say if you think, because of the sugar levels, give food often or add some sugar. What kind of sugar would you suggest to give to your child when she's tube fed? Would you give some lemonade concentrate or some fruit sugars?
Yeah, so nasogastrically fed or gastrostomy fed? Where's the tube?
Yeah.
Right, so it's going gastrostomy. Yeah. So you can put, there are preparations, Maxijule is one of them, Polycal is another one, that are basically a kind of sugar powder that you can add in and will dissolve in the milk. And you do that in a very specific way, so you make a certain percentage of sugar that you put in. So your dietitian needs to help to sort that out.
Not something you do yourself.
Well, you would do it yourself, but you don't need to be instructed on what to do. Yeah. Anybody?
Oh.
Hello. We were told by a paediatrician that our son couldn't, we don't know if he needs growth hormone yet, but he needs open heart surgery, and we were told that he wouldn't be able to have the growth hormone because of the heart condition.
Obviously, it depends a little bit what the heart condition is.
Okay.
If he's going to go for heart surgery, that's the focus. I wouldn't worry about getting the growth hormone started until he's had the heart surgery, recovered from the heart surgery. And then you can have a discussion with your heart doctors and with your paediatrician about whether the particular type of heart problem and the correction with the surgery would contraindicate growth hormone. But I certainly wouldn't be trying to get the growth hormone started, and I'd leave it until he's well through his heart operation.
Hi, you mentioned about pelvic and abdominal scanning. Our son's been on growth hormone for 7 or 8 years, and I don't recall him having one of those scans before. What would what would we be looking for?
So there, I'm thinking about tumour surveillance.
But for CFC, that would be...
Oh, it's the CFC.
So that's different. Yeah.
So we don't need to.
So you don't need to do that, no.
Perfect, thank you.
Yeah. Anybody else? If you think of a question during the day, please write it down, put an email address, give it to Colin or Kath, and I'll get back to you.
I have one more.
I've seen on the listserv recently a question about hypothyroidism, and it's just borderline, and some of the moms like, what? Anybody else have a problem with that? Could that be a possible indication of growth hormone deficiency?
Not necessarily an indication of growth hormone deficiency, but if the thyroid test is not quite right, it needs to be followed up. Because even a relatively minor abnormality in the thyroid test in a child can have an impact on growth. So worth following that up. And you can have different, so when you have a thyroid test, you get 2 results back. The one is the thyroid hormone level itself, and the other is the thyroid stimulating hormone that comes from the pituitary to make the thyroid work. And what you'll occasionally see is a normal thyroid hormone level, but the TSH level's a bit high. And that's called compensated hypothyroidism. So the TSH is working really hard to make the thyroid gland work. And sometimes in those circumstances, if that is a persistent problem, it's worth having some treatment. So thyroid's easy. Blood test, tablets. So worth getting that followed up.
I think the question too was whether or not to take the pills that actually the doctor recommended, but not strongly. It's like, up to you.
Well, you know, I think if you've got a persistent abnormality, I would treat it. You then can monitor it. You can always say, well, I'll do it for a year or 6 months, see how it goes, and then stop again and see if it's gone away. The other thing that's worth checking is antithyroid antibodies. Because if the antibodies are raised, then I really would treat it. So anti-TPO antibody is the test. And that's a problem that's common in the general population, thyroid. Good.
One last question.
My daughter's only just 7 and she started developing breast buds and also hair, but her paediatric doctor doesn't seem to want to do anything about it or just see how it goes is
How
what
it
I've had.
goes. Right. I think at 7, she's only just 7.
She had a really long seizure about a year ago, it lasted 12 hours, and she was pumped full of anti-seizure medicine.
Right.
I just wondered if it seemed to have started about 3 or 4 months after that, whether or not that could have had any effect. Or
I don't think it would be the seizure medication itself. Seizures are, of course, a reflection that the circuits in the brain don't work quite right. And simplistically speaking, during childhood, the reason that you don't go into puberty is that the brain tells the hypothalamus that it's not the right time to do it. If you have an abnormality in brain circuits,
she's got water.
She got water, yeah. Then that signal telling the hypothalamus that it's not time for puberty can go wrong, and therefore the puberty. I would think your daughter does need to have some tests done at that age.
Okay, so
Okay, well, I'm sorry to leave you. I hope you have a great day. Nice to see you all.
thank you very much indeed, Peter, for a really, really helpful talk. I'm sure you'll all agree. And as I said, any questions that grew up in the course of the day, let Kath, Colin or myself know and we can relay them. So, is it me next? Is that right? And I'm not ready, so that's always a good way to start. Am I live streaming all my secrets here?
It's not showing, doesn't show the screen at all well.
Oh, right.
Do you need a clicker?
Yeah. Emma, do you need a clicker?
Oh, if you've got one, that would be lovely.
Colin, because it holds. If you
Moved it away. Nobody watching now. Watching you. Kath.
5 not work. Right, well, all systems go. So I think I've met quite a lot of you in the course of both previous meetings and